So we'll talk about chronic impulsive aggression. This is my disclosure slide. I do have a relationship with a number of companies that make agents used for aggression, for mania, for psychosis, for depression and anxiety. Hopefully they will create even better medications. As you know, we've been aching to get new mechanism drugs, and it's very hard to actually develop them. I've also received grants, but mostly not from the industry. And a lot of the discussion we'll be having is all off-label because there has actually not been a single medication approved for disruptive behavior disorders or the treatment of aggression, different from fever, although many of us would argue that aggression is the fever of child psychiatry. That's what's taking the temperature of these patients. That's what's getting them often in trouble with schools, with peers, and also in higher levels of care. Very briefly on phenomenology, and then I'll talk a lot on controlled efficacy data. And in this talk, I'll only talk a little bit about side effects of antipsychotics. We will talk about antiepileptics and lithium when we talk about bipolar disorder tomorrow. Same with monitoring and management. All right. So basically, aggressive spectrum disorders are not uncommon in the United States. This is older data. This is in the MDD talk. So I'll give you the most recent data on the catchment area. But it was, if you compare depression, anxiety, and disruptive behavior disorders, anxiety trumps. So that about 20% of youths have anxiety disorders, but 16% have disruptive behavior disorders in the United States in a 1-year prevalence rate, and about 8 to 10% have MDD. So it's quite a prevalent condition, what I would suggest almost 1 out of 6, 1 out of 7 kids. There are 2 types of aggression if you wanted to categorize them this way. And there is the predatory, the cool-hearted conduct kind of aggression that is premeditated. And then there is the impulsive affective aggression, reactive, which we see much more of. Fortunately, in a way, because it would be hard to have that many psychopaths in society that really, in a cool-hearted way, lands their aggression. But many of these kids obviously have also comorbidities. That's part of the reason why they can't actually pull it together and control their impulses. And a lot of time it's also a response to the environment that can be quite chronic, or to aggression that they witness around them in the families or neighborhood, or even television and other things. So I think we need to also take that into account, what fosters aggression. And aggression is often a very non-specific reaction to feeling unhappy. My favorite experience of that with my own daughter is that when she was 2 or 2.5, she's a lovely soul and really very sweet. But when she said she wanted to play with me, and I said 5 times, I will, and was still on the computer, not taking my hands off the computer, she suddenly started hitting me. And I thought, whoa, my daughter has never hit anybody, including me, but I actually created that in the moment, by frustrating her, and she wanted my attention. Fortunately, I wasn't black and blue, and she has some other experiences with her mother and sometimes also with me that she gets attention. So it wasn't chronicified, but obviously we need to take all of this into account, that there is a brain that doesn't have enough control, but there's also an environment that fosters that. What can we do? We'll focus today on pharmacologic interventions. In 2004, this is what was given: mood stabilizers, first, so to speak, and then antipsychotics in the list of pharmacologic treatments. But clearly, first we need psychological interventions, behavioral therapy, taking school and families in, group therapy, and individual therapy. And we'll get more into that in a second. Now, you can have 2 broad philosophical approaches to aggression. You can either say you have a disorder-oriented approach, so you don't differentiate the efficacy of agents relative to the specific symptoms. And a famous example is basically the Texas medication algorithm that says, if you have ADHD and aggression, I don't care about the aggression, you first have to treat the ADHD. And I think that makes a lot of sense in that in that setting, because we do know that if you're bombarded with stimuli and you don't know how to react, often that creates impulsivity and can lead to aggression. But then when you've addressed the underlying disorder, then there is another approach, and that could be symptom-oriented, where you focus particularly on certain conditions. So we first need to rule out any comorbidities, really address that. And then the question is there really a disorder, a biological disorder of oppositional defiant disorder? Or is that an expression of something else that we can't really name or treat? That's a little bit a moot point. We will not be able to address that. We don't have enough studies on that. But most likely there are various types of biological lesions or underdevelopments or lack of development that lead to the final common pathway of impulsivity, of aggression. All right, so we'll go through the randomized controlled data for aggression and impulsivity, or irritability it's called, in autism and then in disruptive behavior disorders, just to give you a rundown of the RCTs that exist. And then we'll focus a lot of the remainder on the recently published TMA guidelines, the treatment of maladaptive aggression in youth, where we try to actually target this, tailor this mostly to non-specialists, which is why it also was published in Pediatrics in June this year. Before I do that, I just want to show briefly the development of antipsychotic use in children and adolescents. This is the most recent paper that Mark Olfsen is the first author, and I'm the senior author on, in the archives, where we looked again at the development of antipsychotic prescribing in office-based visits to psychiatrists and non-psychiatrists. And as before, in this time frame that we looked at 2005 to 2009, disruptive behavior disorders are the most commonly cited diagnosis for the use of antipsychotic. 2 out of 3 children visits that involve antipsychotics basically have DBD as the diagnosis, and 1 out of 3 of the adolescent visits. Although obviously there is much more evidence for psychosis and mania, but obviously these conditions are much less frequent than the aggression. And out of the psychiatrist visits, a third of them, 30% of the psychiatrist visit involve an antipsychotic. Okay, so it's a very commonly given medication in the child psychiatry world. Now, we've heard about the RUP group before. That was a very important study looking at risperidone against placebo in an 8-week study. And there was an enormous and overwhelming response rate, although response for aggression is not the same as the response criterion that we set for MDD or mania, where we want a 50% reduction. Here we settle for 25. And as you know, often in schizophrenia, it's even 20% that we set. That tells you a little bit of how efficacious these medications are for certain conditions, but that might also be more of a traditional threshold. Would be nice to look at 50% also. But there was basically an almost 70% response rate on risperidone after just 8 weeks, 100 kids, less than 2 milligrams, 9 years on average, compared to just 12%. And that is an enormous risk difference of more than 50%. So you can already say the number needed to treat after 8 weeks to get 1 more responder on risperidone compared to placebo was 2. After every second patient exposed to risperidone, you get 1 more full responder. That's an enormous effect size. Yeah? I mean, this is unheard of. An effect size in medicine in general, an effect size for statins is in the 30s. Yeah? And an effect size for aspirin is maybe in the 20s to 40s. So this is really huge. This was using the CGI, which some might consider is maybe a blunt tool, but it had to fulfill both the CGI and the 25% reduction. Then kids were stabilized for 6 months open label treatment on risperidone, and a very small sample, 32 kids, then made it into the placebo-controlled discontinuation study, asking the question, can I take the medication in autistic kids? Can I take it away after you've stabilized me? And basically 90% of risperidone patients had response criteria versus only 40% here. So the difference here is about 50. It's again, the number needed to treat to keep someone well is 2. After each second patient that you withdraw a medication, after 2 months of lead-in, 6 months of treatment, that's 8 months, and you say they are responders, after every second patient where you withdraw it, you have a relapse. Now, this is maybe when they know that you take it away and it's done a little fast. That might be a reason for it. But it might also be that these kids have just a biology of their brain that even when they're more stable, you can't really do so much with psychotherapy. They don't change. I'll show you the respective data for disruptive behavior disorder kids, and there it's very different. Much more patients on risperidone relapse and much less on placebo. So if you have a disruptive behavior disorder kid and they are stable for 6 months and you do some psychotherapy, the system has cooled down, most likely you should give them a trial of removal. But I'll show you this in a minute. Now, in the original study in the New England Journal, there was an effect that did even extend to social withdrawal. I mean, we're used to seeing irritability goes down, stereotypy, hyperactivity, but there was some effect on social withdrawal. The hopes were up, maybe there's more of that, but basically we now know it doesn't work for the core symptomatology. Obviously, when the kids are totally aggressive, they might be just in their world and they open up a little, but it's not really treating the underlying core pathology. Then so as you know, risperidone is approved by the FDA for treatment of autistic children and adolescents aged 5 to 17. And we have a second medication that is also approved by the FDA, and this is based on 2 trials. This is here the first flexible dose study, aripiprazole 5 to 15 milligrams, starting at 2 for a week, then 5, then 10, then 15 in a weekly interval. And there was a significant difference that emerged as early as week 1 for irritability and aggression, and that was modeled basically after the RUP study in terms of outcome. Then there was a fixed dose 4-arm study comparing aripiprazole 5, 10, or 15 against placebo, and in the effect size calculations, the 15 did better than 10 or 5, and basically the flexible dose and the 15 milligrams were somewhat similar to the effect size that we've seen with risperidone, but the lower doses were not. Here again, 6, they were also all effective, but they didn't have as much of an effect size. This was also kids 6 to 17 years of age, and 75% of them were 12 or younger. So we have mostly a prepubertal subgroup here. Yes?
Is the difference between 5 and 15 dose?
No, I mean, they didn't evaluate that statistically, but most likely there is none. It's not powered for that. Yeah. I mean, the highest effect size is in the flexible dose studies, showing you might have to go up in the patients that need a higher dose and stay low where you don't need it. If you randomize somebody to 15 and they have side effects, you lose some, so that's where you reduce the efficacy. What is treated with dopamine blockade in the line item analysis? Again, remember, less than 0.2 is a negligible effect size, 0.2 to 0.59 is a small, 0.5 to 0.8, 7.9 is a moderate effect size, and anything 0.8 or higher is a large effect size. And you know it is the disruptive behavior that gets better. The yelling, the screaming, the kicking, all of these things, outbursts there in the high moderate to large effect size, whereas very small effect sizes, although they were still found for depressive symptoms or self-injury. So anything internalizing is not as well treated as clearly the externalizing symptoms.